Welcome to the pro-con debate on the use of corticosteroids for ARDS. I'm Tomoko Fujii from Tokyo, Japan, and we're privileged to have two experts on this topic. Arguing for the use of corticosteroids, we have Professor Djillali Annane, and opposing the use of corticosteroid, we have Professor Manu Shankar. Howdy. So let's look forward to a dynamic discussion. And so, Professor Annane, would you please start first?
Good morning, dear Chair, dear colleagues. So it's a great pleasure to debate with Manu about this important topic that we're all dealing with on a daily basis. So here are my declaration of interest, and of course my main conflict of interest is that I sit on the pro side. So let's start with some of the rationale about using corticosteroids. So what are we talking about? We're talking about this. This is a patient who died following, would say, a week after entering the ICU for ARDS. And one can easily see the huge amount of inflammatory cells that have infiltrated the lung. So no doubt that ARDS hallmark is strong or excessive lung inflammation. And this is this is the driving force of death in this group of patients. So this is it may look like a complex cartoon, but it is not actually. You even do not have to read the words here, only see the colors. So this is 4 different clinical contexts: COVID-19, critical COVID-19, ARDS, regardless the cause of ARDS, sepsis, and the CAR T cells triggered cytokine releasing syndrome. So the figures are almost the same in all these 4 contexts. It is strong activation of inflammatory signaling, resulting in abundant release of pro-inflammatory mediators in the lung, resulting in tissue and cell damage to the lung. And so, do we have something that can oppose to these excess of inflammation in the lung? Yes, we do. Corticosteroids. We know now pretty well how they do work. So in a normal tissue, one can see that there are, as you know, resident cells that are just sentinel, waiting if something happens to act. And indeed, if, for example, a bug, pathogen, enters the lung, breaks the epithelium, immediately you have signals within the tissue from cells that have been damaged, danger-associated molecular patterns, and also from the pathogen itself. These signals will activate the resident cells immediately. And the resident cells, while being activated, they will release a number of mediators with the aim of keeping the bug outside the body, of eradicating the stress and the danger. And one can see that in the same time that pro-inflammatory mediators are released by these activated resident cells, they also release cortisol. It's not cortisol coming from the blood. It's cortisol being stored in the cells in the form of cortisone, and cytokines activated the shuttle that transform cortisone to cortisol, which then is released locally to maintain the balance, to avoid too much of release of chemokines, to avoid too much of attracting new inflammatory cells, and to try to make it a good balance in between enough inflammation to eradicate the pathogen, not too much, not to damage the tissues. And this continues over time. Few hours later, the corticosteroids are going to downregulate almost all the steps of a leukodiabetes, avoiding new neutrophils coming to the inflamed tissue. And days later, when it's time to start repairing the tissues, what happened again, glucocorticoids are released, and then they will shift the macrophages into type anti-inflammatory macrophages, now releasing anti-inflammatory mediators to stop the inflammation, but also increasing some function of these cells like phagocytosis to help clearing the tissues from cells debris, kill bacteria, and so on. And finally, at the ultimate step of inflammation, at the repair, a time to repair the tissue, once again, corticosteroids will intervene to keep a good balance and to avoid excessive healing. So we know well how they do work, and I won't go into the molecular mode of action of corticosteroids. Let's move now to the clinical evidence. Let's start with severe COVID-19. This is many, not all, of the observational studies that were conducted during the first wave of COVID-19. The first information is that in spite of WHO recommended against the use of corticosteroids, many people did use them actually. And one can see here the heterogeneous effects of corticosteroids. You have trials showing that they were harmful, others showing that they improved survival. And they're all right. These are real data. These are actual data, and that they are illustrating. Okay, don't want to come back, but anyway, they are illustrating the heterogeneity in the response to corticosteroids in patients. And then, came the recovery trial that figured out that corticosteroids should be given to patients with COVID-19 that required respiratory support. I like this slide because this slide said that if you want tocilizumab or other anti-IL-6 molecules to work, you need to have corticosteroids. That means if you give tocilizumab alone to critical COVID-19, they might not be as efficient as if they're doing in combination to corticosteroids. So this is why, as you know, corticosteroids is really now recommended. It's a strong recommendation for the management of critical COVID-19 patients, not for patients who do not require oxygen support, and as per definition, ARDS patients all require oxygen support, right? So now, let's move now beyond COVID-19. So this is the latest systematic review that we did together with Bram at McMaster University. Looking at both COVID-19 and non-COVID-19 related ARDS. And one can see here that there is evidence from this systematic review that corticosteroids were resulted in survival benefit in these group of patients, which not too much of heterogeneity across the studies, and substantial effect, even greater effect in non-COVID-19 ARDS than in COVID-19 related ARDS. When we looked at the duration of treatment for ARDS, we divided the studies according to those who treated for 7 days or less versus those who treated for more than 7 days. So it looks like, because one can see that the test for subgroup differences is statistically significant, it looks like that in this group of patients with ARDS, it might be better to have prolonged treatment that is more than 7 days. This data are part of data that we recently released in the Lancet Respiratory Medicine journal. This is an a priori defined subgroup analysis of the approach trial and we looked at patients who had ARDS according to the Berlin criteria at baseline. So one can see here that we had 320 patients with ARDS in the treated group, and we had 328 patients with ARDS in the control arm. And one can see here that while there was no quantitative interaction according to the presence of ARDS at baseline, there was a qualitative interaction. That means that the patients with ARDS had greater benefit from corticosteroids. Looking at survival curves, one can easily see here the substantial effect on survival from corticosteroids in this group of patients, as well as the reduction in the time of mechanical ventilation, weaned off mechanical ventilation earlier, and more patients are weaned off mechanical ventilation at 28 days. Same for weaning of vasopressor, and also the same for the resolution of organ dysfunction as assessed by the SOFA score. So this is why the most recent guidelines, this is from the SCCM, already showed yesterday by Steve Pastores. So what is now recommended is that we suggest giving corticosteroids to adult patients hospitalized with ARDS. This is a conditional recommendation with moderate certainty of evidence. So the rationale is that provide moderate desirable effect driven primarily by moderate certainty of evidence, that it reduces hospital mortality. The effect is more pronounced when given for more than 7 days, and the ideal dose, duration, and timing remains to be investigated. So, and we also, the panel also thought that the undesirable effects of corticosteroids and cost effectiveness remain unknown. The use of corticosteroids deemed feasible and acceptable to healthcare providers, and overall the panel felt the benefits use outweighed its risk. There is some uncertainty about generalizability to the pediatric patients from available data. That multiple dosing strategies are acceptable, and specific choice are better left to the clinician physician. So with some suggestion of using dexamethasone that will reduce workload to your nurse staff, or methylprednisolone. And this is so a summary of the guidelines. So ARDS corticosteroids are recommended. This is a conditional recommendation, and also not showing here, the American Thoracic Society has just updated the ATS guidelines for the management of ARDS, and now they are also suggesting the use of corticosteroids with the same level of certainty of evidence. So I think you have two scientific societies, SCCM on one side, ATS on the other side, that ended up with similar and consistent guidelines for the use of ARDS, of corticosteroids in ARDS patients. So to conclude, I think the available data today allow the conclusion that corticosteroids are associated with improved outcome in critical COVID-19 patients. They may be associated with improved outcomes in non-COVID ARDS patients. And there are a need for further clarifying who should be treated, who should not be treated. So my last comment is that, to me, the question is not should we use corticosteroids, yes or no, but who are the patients who should be treated and who are the patients who should not be treated. And we should really now focus our effort making this discrimination doable at the bedside. Thank you very much.
Thank you very much, Professor. So we're happy to take questions after we listen to the two discussions. So, Professor, please.
Great, thank you. Thank you very much, Djillali. That was fantastic. I'm going to agree with most of the things you say and most of the things you didn't say. So. Right. Acknowledgement, I'm funded through mostly state funding, and the NIHR Clinician Scientist Award means that I have to say these are my views, not necessarily of the Department of Health. I do have an intellectual conflict of interest because we are doing a corticosteroid trial in ARDS, and I'll come back to that right at the end. And I also, like Djillali, run a precision medicine program. So we agree on many things. I don't have any financial conflicts to declare. So I agree totally that ARDS is an inflammatory lung disease, and we are talking about, I'm going to talk about non-COVID ARDS. I agree with Djillali that you got to give it to COVID ARDS because we got evidence for that. What I'm disagreeing here is non-COVID ARDS, and there's a beautiful slides from Djillali highlights why, but I think in the non-COVID ARDS, we got too much uncertainty. If you are a clinician and you're going to give a drug, you will know the dose, the drug, the timing, the duration, and the likely benefit and the side effects in the context of critical illness. And I want you to all think, do you really know what is the right steroid to give for how long in a non-COVID ARDS patient? That's what I want you to think. I'm not talking to you about COVID ARDS. Okay. So the reason why I think we should focus on trying to understand who to give is because of that particular point. We do not know the dose, the duration, the treatment, whether you give it early or late. And what we know is that we are at risk of extrapolating evidence from non-COVID, from COVID ARDS to non-COVID ARDS, from community-acquired pneumonia to ARDS, from sepsis to ARDS. And I just want us to think that should we do that? Okay. And I'm not going to touch on what do guidelines say. Djillali has highlighted that beautifully, and I agree with everything that has been said. So this is a systematic review that we did, asking the question, how do ARDS trials calculate the sample size? And I kind of think that it's a made-up thing, the sample size in ARDS trials. Because the control arm event rate, what is proposed in the sample size calculation is nowhere close to what you actually see. The treatment effect you use in ARDS trials is nothing similar to what you observe for any of the drugs that we have tested thus far. And I kind of took the liberty of doing my own version of the corticosteroid meta-analysis in non-COVID ARDS, and I've actually taken the effort to kind of include the approx paper. That's the last slide there that is hemming this. And I think the overall treatment effect looks like it's great. You know, there is borderline benefit with the predicted interval just under 1. But I want you to just take you through this evidence base for non-COVID ARDS. So let's think about the randomized controlled trials in ARDS thus far. So top half is trials that included ARDS RCT, and the bottom half is the subgroups of sepsis trials that have got ARDS. So between 1987 and 2024, we have managed to randomize 890 patients to steroids and 856 patients to usual care. And I'm fairly certain in this room we have seen more than that ARDS patients. Are we going to use this as our evidence base for treating everybody with ARDS? That's a number of patients randomized in the last 50 years. Okay, let's think about the dose here. So if we take the hydrocortisone equivalent dose, we have tried methylprednisolone for 1 day and given roughly 45,000 milligrams of hydrocortisone in 1 day with a methylprednisolone dosing. We have tried 750 milligrams for 32 days. We have tried 375. We have tried all sorts of things, but here is a consistent kind of dosing, which is 200 milligrams of hydrocortisone plus fludrocortisone for 7 days. But everything else looks like no idea what we're doing. We don't know the dose, the timing. Okay. Let's think about trials stopped early. I think this is an important question. The first trial stopped early. The sample size, if you look at it, it says retrospective power calculation. I'm not joking. New England Journal of Medicine, please look at it. Maduri trial, there is no sample size calculation really. It says finish early. There are many of the other trials are finished early. The subgroup in ARDS RCTs is not applicable. I'm not going to kind of talk about it. And the one other point I want to make in this slide is the Steinberg paper, which is a late ARDS paper. In other words, you're not giving steroids for early ARDS, you're giving steroids after 7 days of ARDS or persistent ARDS. That's a different evidence base. So let's think about these sort of reasons why we should be cautious, as Djillali said, to who to give this to. And the reason why I'm highlighting this trial stopped early for benefit is because of this fundamental point, which is often when you stop trials for early for benefit, you never are able to recapitulate that benefit in a subsequent RCT that is appropriately powered and goes through to completion. So you can't extrapolate too much. The other reason why I think we need to find out how best to treat non-COVID ARDS is the immunobiology of ARDS is beautifully described, Djillali. I'm not going to go even attempt to do this. But I'm asking the question, what are we actually targeting? If we don't know the dose, is there a dose-dependent mechanism here and that we don't know? How do you know what's the right time to give? At the moment, the evidence base is slightly weak. That's my opinion. And I think Djillali made a beautiful point here of the mechanism. I am not going to go through it other than to say that there are glucocorticoid receptor independent mechanisms and glucocorticoid receptor dependent mechanism. And, the glucocorticoid independent mechanism are what we are targeting if you are going to give it early, whereas the delayed effects of that is primarily depend on the glucocorticoid receptor dependent transdepression and transactivation. And we've heard yesterday from Professor Vandenberg, the challenges with understanding this biology in the context of critical illness, and today from Djillali about the glucocorticoid receptor changes that happen in critical illness. So do we really know the dosing and the mechanism that we're targeting in ARDS? And I do think this has one of the points that people made to me when I was thinking about this is, well, there is this trial that's recently published, it's hydrocortisone and placebo in the context of community-acquired pneumonia. And community-acquired pneumonia is the most common etiology of ARDS. Why are we even thinking about doing another trial in ARDS? And I just was wondering, the control arm mortality in the usual care arm is 12% at 28 days and about 15% at 90 days. I don't know what your hospital ARDS mortality is at 90 days. I hope it's not 15. I expect it to be much higher. It's a different population. So extrapolating evidence from community-acquired pneumonia is not a good idea for non-COVID ARDS, is my opinion. And I don't think that this leads me to the final few slides where I want to highlight DEXA-ARDS. DEXA-ARDS is a corticosteroid trial in ARDS patients. This published just before the pandemic. They gave 20 milligrams of dexamethasone for 5 days and 10 milligrams of dexamethasone for the 5 days, so 10 days of total therapy. And their primary outcome was ventilator-free days, and the trial stopped early. And what we see is this beautiful mortality data of 15% absolute risk reduction. I have not been doing critical care trials as long as many of you in the room have, but I am yet to see a drug with a 15% mortality reduction in critically ill patients with sepsis or ARDS. The best you could get is 3 or 4%. So this is, again, the problem of trials stopping early and a kind of challenging interpretation of the efficacy data. What I do think, this is Rohit Saha's work, one of the PhD students is in the group, and We published this in Chest. What I do think here, what we are doing here is to pick all of this evidence base and looking for a fixed and random effect meta-analysis and a Bayesian posterior probability of a future trial showing benefit. And we are fairly certain that sample size somewhere between 400 to 800, you're likely to see a positive trial in ARDS with what we know today. If you give it at the right dose for early ARDS, the best evidence that we have is 20 milligrams of dexamethasone, DEXA-ARDS trial. And that's what we are trying to do. So what we are definitely going to do is an early ARDS, moderate to severe ARDS, RCT. That is important. And I agree with Djillali, we still need to figure out who is the right person to give steroids to. And it is not all patients with non-COVID ARDS. I agree with Djillali that its biological possibility is strong. The risk of adverse events is probably high, but we don't know. There are tremendous knowledge gaps. We are ready to test it in an effectiveness RCT. We're not ready to give it to everybody with non-COVID ARDS. Thank you very much.
Thank you very much. And Professor, would you please come in front? So, are any questions from the floor? So it seems corticosteroids. Oh, okay. So please come. Please take the microphone.
Just a question to Manu.
This is working.
Are you including long-term
Outcomes,
side
yeah.
effects, outcomes in your RCT?
So great
That would be
question.
neat.
So the primary outcome is 60-day mortality, and we are following up with a 6-month, 180-day follow-up, understanding the quality of life, primary healthcare use, return to work, and we want to do some functional assessments, but it's proving tricky to bring them back. So currently it's not, but it's in the plan to do at least in a proportion of patients. Because the ARDS Steinberg trial, which stopped early, they had a reintubation rate and the rehospitalization rate at 6 months. So you're absolutely right. The long-term outcome needs to be sorted. I agree with you.
Thank you. Any question? Yes. Over there.
Should I or should I not give corticosteroids in ARDS due to severe influenza?
So, I think there are ongoing trials that are trying to answer that question of corticosteroids in patients with severe influenza-related pneumonia and ARDS. So my inclination is that meanwhile, awaiting the result from these trials, I would not suggest using corticosteroids in influenza, because we know that the pathomechanism of lung inflammation in influenza is not the same than in COVID-19. For example, it's not this. You got many more neutrophils in the lung with COVID-19 than in patients with influenza. You got more profound lymphopenia in severe influenza than we have seen in COVID-19 patients. So there are striking differences, and so we should not extrapolate what was found in COVID-19 to influenza.
Thanks.
Thank you for the talks. Do you think maybe in the real world there are some centers trying to replicate the study and dosage by Villar at 72, 96 hours? Do you see a potential problem in that? Thank you. Instead of giving in very early.
So, one of the rules of translating an efficacy trial into an effectiveness trial is to
match your protocol as closely to the primary trial as possible, so that your population intervention, the usual care and the outcome is very, very similar, and you can get additional outcomes for sampling your, powering your sample size calculation. The onset of ARDS to treatment often takes that time, because patients come in, they get stabilized, we need to get consent, we need to randomize, do the intervention. So in critical care, that is a challenge, and what we have done in this GUARDS trial at least is to shorten that duration by having a progressive stepwise consenting approach. Patient is unable to provide consent, the family is able to provide consent. If they are not, then the professional legal representative is able to provide consent. So we have 3 levels of consent. So the consent is done within 6 hours of identification of ARDS. So the 72-hour window is because of the weekends and other things, a pragmatic RCT. So I don't think that 72-hour timeline is a inappropriate one. That's what DEXA-ARDS trial used, and that's probably the best thing to do.
And maybe if I can add for practice, there is never rush to initiate corticosteroids, never, in particular in ARDS patients. I think I, as you, are seeing patients with ARDS, and we know that many of them, after 1 or 2 days, they stabilize, start recovering. These patients, they don't need to be exposed to corticosteroids. So I think it's important not to rush. It's important to implement everything that should be implemented to these patients. And then you will have a proportion of patients that will not stabilize, will worsen or will remain severe for more than 2 days or 3 days. And then when you have ruled out any other potential cause that excessive inflammation to explain that worsening, so in these patients, I think in practice is useful to introduce corticosteroids, just as the 2 guidelines from ATS and SCCM now have concluded.
Okay, thank you very much, Professor. So I know we have many questions on this topic, but unfortunately we've run out of time. So thank you again, and thank you for joining us.